Morning.
Good morning. Good morning, everybody. Welcome to San Donato's Hospital CAD Lab. I am very honored to introduce our guest for this case, Dr. Tin, and our members of the team. This is a case of VSD, and to Antonio Saracino explain the case. Thank you.
Our first case is a 5-year-old girl, 23 kilos. She was investigated for a cardiac murmur and was diagnosed with PSD. She's asymptomatic on no medication.
First.
Louder, please.
Her ECG shows a LV hypertrophy with no strain pattern. Chest X-ray shows just a mild dilation of the pulmonary trunk. On the transthoracic echo, we show a high muscular or perimembranous VSD with a diameter of about 5 millimeters, high velocity left to right shunt, and a mild dilation of the left chambers. At the 3D echo, we can see this a view from the left ventricle. Posterior, we see the mitral valve, anterior the aorta, and the VSD looks apparently far enough from the aorta to allow this percutaneous procedure.
Dr. Tin?
It's so on echo, and we found that the patient with a perimembranous VSD, the size about 5 mm. And we did angio already. Let's show the angio.
Next.
No, the first one.
First, yes.
Can you see the angio now?
Yes, pretty.
LV angiogram. Yes, pretty. Yeah, the LV angiogram, we found that it's really the perimembranous, not the high trap muscular VSD with the aneurysm. And you can see on the AB view, 2020 LAL and cranial. And you can see the check go directly to the RVOT. And you can see some hypertrophy of the RVOT, the hypertrophy of muscle in the RVOT. Can you see this? And lateral view also. But on echo, we didn't see any pressure gradient through the RVOT from the LV to the RV to the pulmonary artery. Just a hypertrophy, no pressure gradient. And I think it's a suitable case for device closure. And to turn back to the size of the defect. On angio, we found that the size a little bit smaller than the echo, about 3.5 mm. And you see the length of the defect, about 6 or 7 mm. And what do you need any more information about the defect?
Dr. Tin, as you said, the angiographic dimensions look smaller than what was predicted in the echo. So
yeah.
what was the pulmonary artery pressures and...
Is no significant gradient across the pulmonary artery and the RV.
He found that the pulmonary pressure is normal and no pressure gradient through the RV to RVOT. And it's not pulmonary hypertension.
Okay, let me ask the panelists here, like Carlos, how would you approach this VSD? A restrictive, maybe 3.5 to 4 millimeter, which is well separated from the aortic valve. So with LALV dilatation, so warrants a closure. So what are your device options? How will you approach antegrade, retrograde?
Well, I think there are many ways to skin a cat. Usually I prefer doing the loop, AV loop, and put a device in an antegrade way coming from the LVOT and back to the RV. We are very close to the RVOT here. And probably I would use a symmetric device, 6 millimeters, because I agree with you on angio, it looks smaller than on echo, but it does have hemodynamic significant impact on this ventricle, is enlarged. So there's no doubt we should go and close it. You know, you guys in India have a huge experience going retrograde. I think you could tackle this case in this matter as well, maybe with the ADO2, 6 milliliters. I don't know. What about you, Raul?
Well, I was just wondering, because if you want to look at the color Doppler, you can see that main jet goes downwards to the apex of the right ventricle. And I think that's a fine case to go through the aorta. Go directly to the aorta and close it up without a AV loop.
Joe.
Yes, Dr. Joe?
Yeah. Yeah. We try to cross next.
Yeah, the next.
We try to cross the VSD.
Then Dr.
And,
Joe
you
has
see
got
the
a comment.
Yeah.
Not working, yeah.
Maybe behind, Joey. Behind. There's another one.
There's another one in the back.
I agree you can deal with this in both ways, antegrade or retrograde. Carlos, you mentioned 2 discs, and obviously doing a retrograde and ADO2 would fit in very nicely. Would you consider an ADO1 from a venous side?
The ADO2, you mean?
Thank you.
Sorry?
With the ADO2.
No, an ADO1 from the venous side. Just to not to have anything close to the tricuspid valve.
Yeah, that is another good option. If you are taking an AV circuit, I think ADO1. So Dr. Tin, we have opinions about a symmetric device, like either a symmetric membranous device, which probably Dr. Carlos has got a free access, or a symmetric device like muscular VSD. We can use ADO2, we can use ADO1. What are your thoughts?
Yeah. On echo and on angio, we see the some hypertrophy and of the RVOT, and you see the aneurysm of the VSD. And I think if you use the double disc device, we'll have some problem with RVOT and tricuspid valve also. And we prefer to use a single disc device. I think IDO1 is the suitable device for this patient. I don't want to use the IDO2 or muscular VSD because the disc in the right side maybe have some problem with the tricuspid valve and RVOT also. And we prefer to use the IDO1, but not yet designed until now. It's up to you. And let me show you some problems we worried. You see, when we cross the guide wire tends to move to the RV. Next, tend to move to RV, and even though Luca tried to manipulate many times, and you see how about the IV loop when he made the IV loops. Next. And you see the IV looks very ugly. I think due to the tricuspid entangling. I think the complicated aneurysm and some hypertrophy in RVOT. And it's very easy to entangle the tricuspid valve. And he tried many times. Next. And how to avoid this? We try to we try to change the cut detail. But we lost, and I use my technique. I cross the guide wire first. You see the guide wire cross easily, cross the defect easily. And what did I do next? I push the big tail and back. And you see, where I use a cut pigtail, I need some curve from the cut pigtail to advance the guide wire to the pulmonary artery, and I can avoid the entangling of the tricuspid valve. And you see next, and you see when we make the IV loops, you see the IV looks more beautiful than before. Yeah, you can see now the looks is better. And so for this case, we worried about the tricuspid valve and some hypertrophy of the RVOT also. And it's a reason why we don't want to use the double disc device. We just need a single disc device. And so we, do you agree with me?
Yeah, proof.
And what did we do next? We advanced the sheet. We intend to use the ideal one, and I think the size. What do you think about the size? On echo about 5, on angel about 3.5. How about the size? Can you give me some idea?
Dr. Tin, when you are using an ADO2, would you like to reposition the sheath into the left ventricle or try to deploy it in the aorta and come through the aortic valve into the left ventricular outflow tract?
IDO2 you can deploy anywhere because the device is very soft. You can deploy from the aortic valve and it's safer and easier. IDO1, if you deploy it in the ascending aorta, you should pay attention a little bit when you're crossing the aortic valve. But it's not a big problem, Siva.
Yeah, true.
So then we use the ADO1.
So what size what size ADO1 are you planning to use? Your echo dimension was 5 and your angiography was little less than that. So would you go for an 8.6 device?
I think a 6.4 would
Yeah. But we also intend to use A6, and this reason I use the delivery system 6 branch to advance to the crossing the defect, and because the different size between the echo and the angio, and we will do the angio now after the crossing the delivery system, and now you can do angio now. Angio.
Facciamolo adesso. Okay.
Let me. Yeah, now I will show you the angel after the after crossing the long sheet. We see the size. Angel.
Yes. Ready?
And what do you think?
Turns close.
It's filling.
The shunt almost disappear.
Yeah.
And almost disappear. And I think the size of the defect is not too big.
Yeah,
with the 6 branch delivery system, I think the size about 2.5, and really the size maximum size of the defect about 3 or 3.5. Yeah.
So even
What
a
do you think, Siva?
6.4 device probably should be fine.
Yeah, I think if 6.4 can be, it must be better than the A6.
Yes,
Right.
we agree. Yes, 6 French sheath, outer diameter still will be somewhere around 3.5 or so. Being a braided sheath, I think a 6.4 should be able to fit in. What do you say, Carlos?
Yeah, I would go with the 6.4. I'm not sure if perimembranous VSD devices are available here in Europe from LifeTech, maybe. Can anybody peep in and tell us about? Yes, Kevin. Or other devices. Because usually, that's my personal preference. I use perimembranous VSD devices for perimembranous VSD devices. So.
Yeah, you know, the LifeTech devices are available, and similarly the Oclatech device would work here, but maybe a 5mm symmetric LifeTech would be fine here too.
Yeah, I agree.
And they are soft as well, so the problem of AV block is probably will be lesser than
maybe the ADO1 is cheaper. I don't know.
Carlos, Dr. Joe raised the point of avoiding a disc to protrude into the right ventricular inflow region. So what advantage do you see by using a symmetric membranous LifeTech VSD device over a simple ADO1 device which will not have any retention skirt?
Well, I mean, it's just more comfortable to have another disc on the right side. Of course, you have to take care not to catch the tricuspid valve, but I think Tin demonstrated very nicely when you should not proceed and when the wire is entangled within the tricuspid valve, and then he changed the strategy, used a pigtail, the wire went to the PAs. So I think you could go either way here. I don't see any problem using a double disc device here. We've had big problems with the tricuspid valve. I think the main issue always is heart block which occurs in 1-2% of patients. No matter what device you use, I don't think the AD01 would result in a lower rate of block, but that's we don't know. I mean, there's no evidence. There are so many devices available, so it's hard. They are scattered to make a good clinical judgment.
But at least the clamp on the device will be avoided if you don't use a symmetric device. The symmetric device, the two discs are separated by 3 millimeters.
Yeah, I think so.
So there will be some amount of clamping by the two discs.
Well, the LifeTech device is softer than the AD01. There's no doubt about it. So, you know, you cannot have everything in just a single device. You have to give and take. So I think you could get away either with the 5 or a 6 LifeTech device. But after Teen demonstrated this nice angel, I think a 5 would work as a charm here. But let's see. I mean, that's great. I've never used the AD01 to close the VSD. Everybody uses, but
yeah,
and I think it would be fine.
In this particular case, there is a muscular portion in some view which invite for maybe a double discal device because it's not so close to the aortic valve in some view. There is a muscular rim, a very small muscular rim.
Yeah, I agree. It's a higher location defect.
Yes, Tin, we see your device in the arch of the aorta.
Yeah, we're waiting for you.
Yeah. Go.
And I think we changed our mind. At first, we intend to use the 8x6. But after angiography with the sheath crossing, we changed, just use the 6.4 is better. And we try with the 6.4 mm device. And now I advanced the sheath, the device to the sheath, inside the sheath. Now I put back the whole system underneath the carina. You see underneath the bronchus, you see there? And it means it's the under bronchus, it means it's the ascending aorta. I don't want to deploy a little bit higher because I don't want to damage some branches of the aorta, carotid or subclavian or somewhere. And underneath the bronchus, I think it's okay. Now I deploy, open the disc, the left side disc, and you see, and now we pull back. Can you pull back very slowly? I don't pull open the left side disc. You can see, and I can use the pigtail to check where the aortic valve, there, and you see the device still above the aortic valve. And I bring back, you see the device drop into the LV. Yeah. And what I do next, I push the pigtail into the LV, and we do angio to check about this. But you see, now you can see now the device, I think you see the pigtail. Pigtail is the septum, the ventricle septum. The device a little bit far from the septum. And then I bring the device a little bit to the septum. I bring the device a little bit to the septum. Yeah, and now we do angio now. Okay, you can see the angio now. And you see the left side, this looks very beautiful now. And what you do next, just deploy the remain. Okay, I deploy the remain, and I hold the sheath, I hold the cable and put back the sheath, and everything I think is be okay. And now you can do angio now, the second one. What do you think?
Looks good.
Beautiful.
You think the device still in the left side a lot? In the left side, you want to bring back to the right side a little bit more, or just it's okay?
Yeah, the right ventricular disc is showing a little bulge, and there is a waist formation. So I think your device is quite stable.
Nicely done.
Yeah.
Can I ask you guys to measure the waist of the device?
Yeah, can you measure the weight of the device? It means we don't want to oversize a lot.
And there's a,
there's
a comment from...
I think I should bring... I bring a little bit more to the RV.
Tin, Dr. Shak has a question to you.
Yeah, Tin,
Yeah.
I wanted to make a point about if you look at the original angiogram, you can easily make yourself talk yourself into putting a double disc device because you'll think there is quite a length to...
Yeah.
There's quite a length to the tunnel, if you like, whereas the echo gives a better appearance. And again, with the current deployment, it looks as if the device could do with pulling in a little bit more in order for it to stick out into the right ventricle a little bit more. It's the length of that tunnel, really, which ultimately will determine how much you pull in or what sort of device you put in.
Yeah, I think so. You see, I put back a device a little bit to the right side. And you see now the device more stable, not move a lot. You see, I retrieve the weight, the body weight of the device and put back. And you see now, I think it's more stable. How about echo now? Can you check echo? How about the aortic valve? Is any aortic regurgitation?
Tin, Dr. Dietmar has got a point to make.
Hi, Tin. I have seen you just 5 minutes ago here, and now you answer cath lab. It's unbelievable. So I have used only 3 times, like Carlos, I do 1, and 2 times it embolized. And so I don't use it again, but I don't know when is the device milking out. It looks very nice, like this one, and after half day, 1 day later, the device was anywhere, but not in the VST. So my question is, how can you avoid... No. Chuck is coming back. Yeah. This is dangerous. So, yes, tell me what you can do again.
Dietmar, I think on 3 cases, your 3 cases. Yeah.
Sorry to interrupt you.
Hold on.
Guys.
Yeah.
Yes.
Mario.
Yes. I did my best to join the team here in San Donato, but I know that Tin is very, very quick, so I had no time to be here. Well, just in time to listen the comments for Dietmar. So thank you very much for your concern, Dietmar, but hopefully I'm pretty sure that when Tin release the device, it will stay there in the VSD.
Mario, I was going to make the point that shows Dietmar's incompetence, not the device.
Oh, yes, absolutely. Okay, Tin, what do you think?
You cannot recommend any mistakes. That's a pity.
Okay, Tin, what do you think?
I think
please go back to the Flora picture, and maybe we will have a look at the echo large.
Yeah.
Yes?
I think on your 3 cases embolized, I think the devices move to the aorta.
Yes.
And to the left side. I think due to the device not go to the right side. You think it's go to the right side, but it's not really. You see at the first attempt, the device a little bit in the left side, and you see the device still moving.
All right.
And I should pull back the device to the right side.
So you mean you feel resistance, some kind of resistance?
Yeah. Next, the first. Next.
We will review the angel.
Yeah. Previous. No, sorry. Previous.
I like your Vietnamese hands.
Yeah, you see now, it looks okay. Everything looks okay. But you see the left side is still moving together.
Yeah.
And so I don't think it's safe. Next. And so I retrieve. You see, I retrieve the weight of the device and pull back to the right side. And what you see, now the device more stable. And you can do angel now. You can see now.
Right. We will repeat an angel Tin now, yes.
Now you see the device now is more stable.
Okay.
And so I think all your cases maybe embolized to the aorta.
Okay, forget it. So you're ready to release the device?
Yeah, check and echo. Echo is looks okay.
Can you see both Angel and Floro? Can you see David in the audience?
Yes. Yes, we do see.
All right.
Yeah, I think so.
Okay.
So on echo, we see that the aortic valve is working well. There is no obstruction on the alveoli.
Tin, Dr. Bharat has got a question to you.
Yeah.
The length of the VSD, I think, is a matter of concern. And embolization on the aortic side is not uncommon with such VSDs. Many times when the ADO1 is on the cable, you see the waist and you find that the lie is excellent, but you will see the amount of recoil once you release it. And things may not look the same after release, what they look when you are on cable. So I think that Dittmer's point is well taken.
If there is a mushrooming of the pulmonary end a little bit on the RV side, that means there is a waist formation on the device. Usually it's pretty stable. In this view below, that shallow LAO cranial, the PA end is really looking bulged compared to the waist of the device. So I think it's reasonably stable. Please go ahead.
Yep. Thomas.
Yeah, Bharat, you see on the lateral view. Can you see on lateral view the device a little bit
pointing downwards?
Yeah, pointing down due to the cable.
In lateral view,
you see some resolution.
Is Occlutech long shank device an option to have a longer body of the device to give more security, and also the body has a slightly different shape, may give more stability?
Yeah.
But the PDA from Occlutech have some resolution and hemolysis. Really, it's not good for the VSD closer. The VSD device better, but the PDA is some resolution. I have some experience with the PDA Occlutech device.
So, Tin, you're going to release.
Are you happy for release?
Yeah.
And I release now. Dietmar, I hope it's still here. Okay.
Yeah,
and
the device is still there.
The final
Very
angel.
good. Can you see the echo?
Angel.
And we repeat an echo and an angel, yeah. Oh, that's great.
Yeah, you see the left side is of the device not touch the aortic valve. And the device is inside the total length of the defect. I think it's a good, almost no resolution.
Yeah.
Can you check the trachea switch valve? I saw before have some trachea valve regurgitation, now almost disappear.
Perfect.
Okay. And any comments?
No, it's just perfect. Congrats.
It looks very...
Yeah, very good, guys.
So,
I think there is no need to repeat an aortogram, Tin, yes?
Yeah, I don't
The aortic valve looks perfect on echo, so...
Can you see echo now?
We don't need to repeat an aortogram because the aortic valve is working perfectly. There's zero aortic regurgitation, no residual shunts. So I think that's a perfect result. Very good, guys.
Mario.
Yes?
Mario.
Yes.
Mario, this is Carlos. Let me ask you a question. How do you manage these patients in terms of surveillance for heart block, like the Holter, standard ECG, telemonitoring? What's your policy here in San Donato?
Well, the problem, the issue of heart block is actually part of the history. And it happened many years ago when we'd been using other devices. As you know, the so-called membranous VSD occluder from Amplatzer that was really designed for perimembranous VSD, and the design was okay, but the device was too stiff, and this is going to be the problem of heart block. But when we started using, for example, ADO1, like in this case that Tin did, we no experience any heart block at all. Tin, any other comments about that?
Yeah, when we changed from so-called the modified device, not the Amblas VSD device, almost no IV block. I don't have any cases with the IV block.
Yeah, that's right. I mean, there are many devices available now, but for such an anatomy, I think the AD01 did a perfect job, I think. And well, we did several cases in such a kind of anatomy, and we are very happy about that, yes. There are also other devices, of course, Occlutech, as you mentioned.
Yeah.
Well, the new MFO from LifeTech is also very useful. We started very recently, experienced with very, very promising results. But I think, well, this is an example where the high muscular VSD, I would call it, can be closed very, very successfully with the AD01, as you did. Congratulations, guys.
Yeah, thank you.
Thank you. Let me ask the question to the audience. How many of you have experienced complete heart block with an AD01 device? Is it only one person has seen so far? Anybody else in the audience who have seen a complete heart block with AD01 device or AD01-like devices? Okay. Yeah, go ahead, please.
Zahia Saliba from Beirut. I have one case, one late appearance of AV block, complete AV block with AD01. The 18 months later, the patient came for AV block, and we put a pacemaker. And it was initially oversized, I think. I put in 8.6 instead of 6.4. It's like this anatomy. And the device was squeezed in the VSD. And later, the shape of the device, it take its initial shape. So I think the tension was the cause of AV block.
Yeah. Well, that's Tin, last final comment by you.
I think the 18 months is the very small baby. We don't try to close for small baby. It's
that's right.
Because LVOT, RVOT, and IV node, IV conduction system very close to the defect, and we don't try to close the very small baby.
Yeah, that's right. In fact, when we published many years ago our European registry, actually the most important risk factor for heart block was the age of the patient.
We had...
okay, so if you don't mind, I think we have to carry on. What?
We had the incidence of heart block in one of our cases. We used a 10/8 in a 3-year-old child. The defect was peribimbinous in location, and the heart block appeared after about 4 weeks. The child came back with 3 episodes of syncope. We admitted the child, and there was complete heart block, for which we observed for 2 days, and later on it had to be taken out surgically. We thought that the child would need a pacemaker. Fortunately enough, after about 4 days, when the child was on temporary pacemaker, he regained sinus rhythm, and thereafter he didn't need any permanent pacemaker implantation.
Yeah.
This was a 10/8.
So it's likely that the incidence of heart block in a AD01 device is much, much lower than the previous asymmetric VSD device, but still needs to be monitored.
Sure. We have to monitor on the long-term follow-up all these patients, but we are confident that it will go okay. So I think we start the procedure, and the results is perfect so far. So thank you very much for Alessia. And so we can disconnect, and in the audience, the conference room, you can carry on with the lectures. Thank you very much. Bye.
Thanks, Mario.
Thank you.